Good afternoon, everyone, and welcome to Medical Grand Rounds. It's 12 noon, so we'll get started. I would like to just remind everyone to please let us know that you're present at today's round by filling out a brief survey that you'll receive at the end of Grand Rounds, and to please enter your questions in the chat at the end of the presentation. And it's with great pleasure today that our Grand Round speaker comes to us from the Division of Geriatrics, and I will ask Dr. José Moret from the Geriatrics, the Chief of the Division, to please introduce our speaker today. José, thank you for being here.
Thank you, Nadia. It is a real pleasure, in fact, to introduce Martine, Dr. Martine Extermann. We know each other for some time already. I don't want to precise the date, but Dr. Extermann, she is a full professor of oncology and medicine at the University of South Florida, and she's also the program leader of the Senior Adult Oncology program at the Moffitt Center, Cancer Center. She is born and obtained her medical degree and PhD from University of Geneva, Switzerland. And she's also board certified in internal medicine and oncology hematology from Switzerland, as well as from American Board of Internal Medicine. She worked at Moffitt since 1994 and has been, a faculty member since 1997. Of interest to me is that her research focus on cancer in older adults. Her main areas of investigations are comorbidity, comprehensive assessment, and prediction prevention of treatment toxicity in older patients with cancer. I mean, her CV and accomplishments is extraordinary, and it would take another 10 minutes of introduction, but suffice to say that she was awarded the ASCO 2009 with the BG Kennedy Award of Scientific Excellence in Geriatric Oncology, and she participates in numerous committees and agencies in research, all to do with oncology, specifically for older adults. It's a real pleasure to have Dr. Martine Extermann with us, and she's going to talk about updates in geriatric oncology. So, Dr. Extermann.
Well, thank you very much, Dr. It's a pleasure to be with you virtually. Probably it will be very beautiful to see Montreal right now, but we'll do it virtually, and I can tell you the weather is fantastic in Florida. So, updates in geriatric oncology. This is going to be by necessity selected program because there are many things happening in the field of geriatric oncology. So just for disclosures, I have a few consultancies and honoraria, nothing major for this talk. And what we are going to try to do in this grand round is be able to understand and apply the results of recent randomized studies of geriatric intervention in older cancer patients. I want to improve your knowledge of the tolerance of older patients to targeted and immunologic cancer therapy. And I also want you to be cognizant of the key priorities in research and clinical developments in geriatric oncology. I think those of you who are research-oriented may find some good ideas here if you want to develop your careers or your research ideas. So let's start with randomized studies. There have been a whole collection of randomized studies in the last 2 years that really answer a key question that we have been asking for 20 years since we started doing geriatric oncology is, once we identified that patients had geriatric problems along with their cancer, and once we have identified that geriatric assessment identified things that were predictive of the management of cancer, the key question has been, well, okay, fine. If we do find things and we do something about it, is it going to change the outcome of the cancer patients, Or is the outcome entirely directed by the cancer and that's it? You know, geriatrics is an academic exercise. So we have some answers to that, and I'm going to share them with you. I'm going to start with several examples of studies that were assessing cancer patients receiving systemic treatment, either pure chemotherapy or chemotherapy and targeted therapies or a mix. So the first study was done at City of Hope. It is the GAIN trial, and it had 600 patients. And the intervention that they did was to use a short geriatric screening developed by Arti Huria with ADL, IADLs, the OARS, GDS, and a few other things. And then a geriatric multidisciplinary team was making recommendation, and a geriatric nurse practitioner was helping the people in that cancer center to implement these recommendations. And what they found is they had a decrease of severe toxicity by 10% in these patients, and this was significant. They did not see a difference in emergency room visit or hospitalization or length of stay. They had a higher implementation of advanced directive completions. The second study is a study from Australia, the INTEGRATE study. It was a bit shorter, 150, a bit smaller, 150 patients. And this one had a geriatrician-led comprehensive geriatric assessment and management integrated with their cancer care. So they were really doing both together with a geriatrician. And what they found is they had 20% less early discontinuation of treatment. And they also had a marked decrease in admissions, 41%, and marked decrease in ER visit. And this was significantly leading to a 7-day per person per year decrease in hospital stays. So that one was positive for decrease in hospital admissions. They also had a quality of life score, and at the end of the treatment, that LFI score was 72 instead of 58, and that was highly significant. As far as quality of life scores go, when they are rounded to 100, usually a difference of 7 to 10 points is a moderately significant difference. Here we have a difference of 15 points. Then the GAP70 was conducted by Mohile and the Rochester, New York NCORP in the US. And they had 700 patients, and they had private practices, and they did a cluster randomization. Some practices did do the geriatric assessment, others did not. And what they did is they did a geriatric screening, again, very similar to the Huria screening. And then they gave a summary to the oncologist with the recommendation from the central expert team at the University of Rochester and about what to implement. And so with that, they decreased by 20% the risk of severe toxicity from treatment. They had no difference in survival at 6 months. It can be a good thing, means that when the critique that people say is, well, yeah, you decrease toxicity because you decrease the dose, but is it as effective? Well, they didn't lose any effectiveness. So that's, and interestingly, they had more initial dose reductions, but they had less dose modifications during treatment. So in other words, they were hitting the right dose from the get-go. This is another one, Orum from Denmark. They had a geriatric evaluation and follow-up in 363 patients. And with that, they had a treatment completion rates of 61% versus 52%. It did not quite reach significance. And they had no difference in ADLs at 90 days. Now, I have to say, they had a pretty complete frontline consultation. That whole initial geriatric consultation was given to the oncologist, whether the patient was randomized to the follow-up or not. And that may have made it more difficult to obtain a positive study because oncologists might have implemented some of these recommendations. they have some very interesting subgroup analysis about which groups benefit the most. So that's interesting to look at that article. Another study that was published here is the Geriatric study. So all the previous studies were on all cancers. This one is specifically in colon cancer. And what we see is that CGAB's recommendation led to a much higher rate of treatment completion, 45% versus 28%. And here again, 11% of decrease in severe toxicity from chemo. No difference in hospitalizations, no difference in PFS and OS. Quality of life was better. The burden of illness was lower, and they had an increased mobility throughout the treatment. I didn't include what is not a formally randomized study. It's a quasi-randomized study where they had two parallel cohorts of patients, and one had a CGA screen and was referred to the geriatrician if they had problems on that, and the other cohort was not screened. This one had an increase of 22% of receiving treatment as planned, and there was a trend to less severe toxicity. Again, no significant difference at 6 months in overall survival, but the trend was in favor of the geriatric intervention. And then there is a Canadian study that, of course, you may be aware of, which was conducted by Martine. It's the 5C study. And they enrolled 350 patients, and they did a comprehensive geriatric assessment and monthly phone calls. It was not quite at the baseline. The contacts were initiated after treatment was started. So this did not influence the treatment chosen. The idea was to control the symptoms from the treatment. It was a negative study. There was no difference in quality of life. IADL, and as I said, the CGA was done on or after the first day of treatment, so did not influence the treatment choice. Before I reach some conclusions, let's mention surgical studies, because this is another area where people are trying to see if a perioperative geriatric assessment might change outcome. And the first one is a study from Massachusetts General Hospital, and 160 patients were enrolled. Some of them did not undergo surgery for a couple of reasons. And they had a geriatric assessment preoperatively, and then postoperatively an inpatient follow-up by a geriatrician. And in intent to treat, they saw no difference. However, about half of the patients did not go to the geriatrician's office prior to surgery because it was in another building. They had to come to another appointment. And so they kind of skipped that preoperative assessment and only had the post-op intervention. If you did the treatment as planned, then they had a lower length of stay and ICU stay, and there was no difference in readmission. Both ITT and PP analysis showed better ESAS score and less depression. There is an older study that's 20 years ago, was done by Ruth McCorkle and the geriatric nurse practitioners at Yale. And they had 365 patients that were randomized to a post-op intervention. And that one, after discharge for 1 month, they had interventions by a geriatric nurse practitioner, which were a mix of at-home visits and phone calls in between, 2 contacts a week. And with that, they had an impressive improvement of 2-year survival with a hazard ratio of 2.02. Okay, it was an absolute reduction for patients with advanced disease of 27%. That was published in JAGS, so the oncologists don't read JAGS, and therefore the impact was fairly low. If it had been a drug, we would have it plastered all over the place, but that was an impressive impact, probably by early detection of complications or prevention of functional decline, allowing them to get better adjuvant treatment, and that's what would explain the survival of these advanced stage patients. That's kind of my interpretation of it. So So Thierry Rostov did a very good summary of all these studies. In the Journal of Clinical Oncology, there is a special issue on geriatric oncology that I recommend to you. And she reviewed a much larger number of studies than the ones I have presented. And this is the summary of the result. The most consistent effect is really the decrease of toxicity and complications. And 60% of the studies, 2/3 of the studies, show a decrease in toxicity and complication. There have 6 studies that looked at treatment completion, and again, 2/3 of them show an improvement in treatment completion. Mortality is a harder goal to reach. Everybody knows that it's hard to reach in oncology. Of the 10 studies, only 2 did show a positive difference in mortality. They looked at some patient-centered outcomes. One study had a positive effect, another had a mixed effect, and 2 had no difference. And then the healthcare utilization studies have a number of outcomes. And I think that depends also on how you define healthcare utilization and what you consider good or not in healthcare utilization. If you detect a problem with a geriatric assessment and you send them to another practitioner, that would be a good increase in healthcare utilization. If you try to avoid hospitalizations and you have more hospitalization, that would be a bad increase in healthcare utilization. So I think in that category, you have to dig into the detail to figure out what the geriatric intervention does. So my personal interpretation of that is that various models of intervention have proven effective. And you can do inpatient interventions, you can do outpatient interventions in the same institution, you can do models with a geriatrician visiting or model with an integrated team, you can do a private practice model with a central reference core that gives advice based on a screening tool that has been done in these private practices. Of course, we'll have to figure out with more time what components of this intervention are essential and which ones can be adapted to context. The most consistent side effect is the reduction of toxicity. That's really very consistent across studies, and whatever the mechanism of it is, it's present. I think that initiating the intervention prior to treatment initiation is key. For that, I would say that the 5C study started after initiation of treatment and did not have the impact by pure management it had. And the Massachusetts surgical studies also show that the preoperative consultation was a very important component for the effectiveness of the intervention. So if you design studies of geriatric intervention in cancer patients, you have to have the first step of the intervention prior to treatment initiation so that we can assess decision, influence decision, and influence the treatment shape. Also, implementing the full intervention matters. Again, if you do half of it, that doesn't seem to work quite as well in the previous studies we have seen so far. So very, I would say we have level 1 evidence now that it works. Geriatric intervention works. So for all the geriatricians in the audience, roll your sleeve. You are going to be in high demand. Let's switch gears. We speak a lot of the side effects of chemotherapy, and we've done for years. But what about targeted and immune therapies, which are more recent treatment and probably less well known to a general audience? So what can we say about their use in our older cancer patients? The targeted therapies is a fast-moving field. Okay, the FDA approves about 1 new targeted anti-cancer therapy per month. So even oncologists have a very hard time following up. Okay, so we are trying to do our best, and we use our electronic means of keeping track. molecular studies are increasingly central to oncology. Oncologists are a pathologically dependent species. Okay, we treat whatever the pathologist tells us to treat. I mean, that's the truth of the matter, so we are very dependent on them, and increasingly, molecular studies are important. That unfortunately also adds to the workup. It adds 1 to 3 weeks to the workup of these patients because you have to wait for the result of the molecular studies. However, that delay is also an opportunity for the geriatrician because you can do prehabilitation interventions in that 1 to 3 week delay. Any oncologist who pretends that you don't have the time to do a geriatric intervention is deluded because they take on average a month before they start treatment. Okay, by the time they've repeated the PET scan, they placed the port, they did an echo, they did get a Foundation 1 report, all that takes several weeks. So we have to exploit that window to do these geriatric interventions that we wanted to do prior to treatment. There is also many drugs that target the host tumor interactions. Checkpoint inhibitors, for example, or anti-VEGF inhibitors target really the immune system or the vascular endothelial growth factor system, vascularization of the tumor. And yet, there is a really delay and lag of geriatric studies, aging studies, that look at the impact of aging on the cancer microenvironment and the effectiveness of these drugs. And I think we could learn about that. So let's look at some examples. One class of drugs is what we call the tyrosine kinase inhibitors. It's a very large drug. It inhibits anything like the BCR-ABL fusion protein, various kinase. Imatinib was the very first one of them that launched the whole field of targeted therapy, but I cited a few names of them. There is a Bruton kinase inhibitor, of which lymphocytes are very dependent. And the best known of those is ibrutinib. Ibrutinib is now the frontline treatment for chronic lymphocytic leukemia. Chemotherapy has receded behind ibrutinib. Acalabrutinib is another one similar to it. And there are others. A category of kinase inhibitors that is used in a lot of solid tumors is what we call the mTOR inhibitors, the PIK3A inhibitors. And this is the pathway that is common to cell cycle regulation and growth and glucose management. And that plays a role in the side effect of this category of drugs. But it's a very effective one. Everolimus is probably the most used of them. Sirolimus or temsirolimus are used in kidney cancer as well. Alpelisib is a PIK3CA inhibitor used in breast cancer. And then you have the cyclin-dependent kinase 4/6 inhibitors. And that's palbociclib, ribociclib, or abemaciclib. These are drugs we give in breast cancer to reinforce the response to hormonal therapy. And it's very largely done. And so you very likely will see these metastatic breast cancer patients arrive in your clinic with this type of treatments. What issues do these treatments have in older patients? Well, almost all of these drugs are P450 metabolized. So you are going to have drug interactions on P450. If you are trying to prescribe something that's P450 metabolized, just check your e-resource. Go to UpToDate, Micromedex, or whichever lexicon, whichever database you use, and verify that drug interactions are not creating a problem. For example, amiodarone and ibrutinib, you have to reduce the dose of ibrutinib by 60% if you give amiodarone. So these are sometimes very significant. The side effect of these drugs, many of them have some GI symptoms, diarrhea, nausea. They can make you tired. They can have some liver and heme toxicities to different degree depending on which one. Typical for ibrutinib, it also has a significant risk of triggering atrial fibrillation. That may or may not be a problem depending on the patient. If the patient is already in atrial fibrillation, it's usually not an issue. Otherwise, acalabrutinib, which can be given for the same indications, has less risk of triggering an AFib. Overall, I would say carefully check for concomitant medications. You can modify the dose. I've done that sometime if a patient needed a cardiac drug. We were adjusting each drug to allow dosages to be optimized. Renal function is usually not an issue. As I said, they are liver metabolized. And then the tolerance is roughly similar to what we would see in younger people, but these are not drugs without side effects. Initially, imatinib is such an easy to tolerate drugs. Everybody said, oh, okay, we are done with the chemotherapy type toxicities, yippee. Well, no. Targeted therapies can have side effects. If you take alpelisib, you can have hypoglycemia that you have to manage. If you, some of them, as we said, have GI side effects. So you have to be knowledgeable and know how to use them. A second group is the VEGF inhibitors, and they come in two flavors. One is antibodies like bevacizumab or ramucirumab, and the other are small molecule VEGF pathway inhibitors like sunitinib, sorafenib, or aflibercept. These are used mostly in digestive tumor or kidney cancer. Drug interactions, the antibodies do not particularly have that. Kinase inhibitors, same thing as the other kinase inhibitors. The side effects are hypertension, fatigue. You can have bleeding or thrombosis, both ways, and it creates a delayed wound healing. So you have to stop a VEGF inhibitor 4 weeks before any surgery and wait a bit after surgery to restart. So this is important to know. You have the blood pressure effects are usually treatable. Significant bleeding is an indication to stop them. And a contraindication is, of course, any active bleeding or recent active bleeding. A minor nosebleed is okay. I want also to say that the indication in young patients do not automatically translate in older patients. In lung cancer, you have a benefit of adding bevacizumab to chemotherapy. You do not have the same benefit in patients above the age of 70 or 75 because the side effects are beginning to outweigh the risk, the bleeding and the thrombotic side effects. Checkpoint inhibitors, that's been the wonder kid of oncology for the last 5 to 10 years. And basically, to refresh everybody's memory, you have a tumor cells that is attacked by a T cell receptor, by a T cell, and usually you have an interaction with the major histocompatibility complex presented peptide and a secondary signal that is supposed to activate the cells. But if the tumor cell expresses PD-L1 at a high level, then they will inhibit actually the toxic reaction. And then the T cells present these tumors to dendritic cells. And here you have another set of inhibitors, CTLA4 and CD28, which interacts between the T cell and the dendritic cells. And so the key drugs that we have are the PD-1 inhibitors, nivolumab and pembrolizumab, or you can have PD-L1 inhibitors, so for example, durvalumab and atezolizumab. And then there is another blockage, which is CTLA4, and ipilimumab and tremelimumab are the drugs that block that. Historically, ipilimumab was actually the first successful checkpoint inhibitor, but it has more side effects than nivolumab and pembrolizumab. So it tends to be given in some settings and it increases toxicity. But in many settings, we rely rather on PD-1 or PD-L1 inhibitors. How do they work in older patients? We have a lot of data actually on that. And this is just one example, one recent example in melanoma patients. You can see that for survival improvement, the patients who are 75 and above do just as well as younger patients and have a really nice 3-year survival. The median is around probably 2 years here for both of these groups, which is infinitely better than it was for melanoma. As far as side effects are concerned, many patients will have a bit of side effects. High-grade side effects are about 10% of patients. Dermatitis can happen. It's a rash, just a regular drug type rash. Hypothyroidism happens, notably with pembrolizumab, and it can be, usually when it happens, it's not subtle. Your T4 is at 0 and your TSH is at 50. We watch that when we give pembrolizumab every other cycle, we check the TSH, but always think about that. If you have a patient on the immune checkpoint inhibitors, thyroid might be affected. Arthritis, colitis, pneumonitis can happen. After that, it becomes also less frequent. Older patients tend to have a little more of some side effect, the hypothyroidism, the arthritis, or the nephritis problems, but it's not a dramatic difference. An interesting question for our senior people who also have a lot of comorbidities is, how safe is it to give a checkpoint inhibitor in somebody who has an autoimmune disease? Okay, if you block the checkpoint, you reactivate the immune system no matter where it is active, which is the source of the side effects. And there are multiple retrospective studies, no prospective studies. The patients were excluded actually from the prospective trials. Here is one of the first ones, multicentric. They had 57 melanoma patients with pre-existing autoimmune diseases, got an anti-PD-1 treatment, and about a third of them had a flare-up of their autoimmune disease during immunosuppression. But only 2 patients did DC treatment due to flare. Usually you are initiating high-dose prednisone or whatever immunosuppressive treatment was appropriate for their autoimmune disease, and that was working. And an interesting thing with checkpoint inhibitors is they can't be on steroid when you start. Okay, you can't start them in somebody who is on active immune suppression because you would nullify the effect. But if you start and then they develop an immune reaction and you give immunosuppressant, you will retain the effect. It looks like it's a trigger effect, an epitope spreading effect, and you kind of reinitiate your immune reaction. And once it's rolling, if you need to give steroids, you can. This is a recent review of such studies of patients in immune disease, and yeah, about 30% reactivation across the board. So depending on the immune disease you have, you may risk that. Others, you may say, well, no, I just don't want to reactivate that disease, and then that will be a contraindication for your checkpoint inhibitors. As I mentioned, the data showed effectiveness, and the tolerance seems to be quite okay. Now, speaking of targeted therapy, I would like to highlight one particular disease where we long have been fairly nihilistic for older patients, and that may be about to change. And that disease is acute myelogenous leukemia. We've made progress over the years in the treatment of acute myelogenous leukemia. And for younger patients in 75, only 20% lived 5 years. Now, 25 years later, it's above 50%, okay? Or it's even 70% now in 2012 to 2018, okay? And then things get worse. And when you are 75 and older, there has been essentially no progress since 1975. Okay, your 5-year survival is still a miserable less than 5%. And even if you're 65 to 74, you're still only down to 15%. So there is really a need for improvement that's quite critical. So we did look at that. We did a large grant, and we did a systematic review of 13,000 patients that we pulled from studies and study subgroups of patients aged 70 and older. That's, to my knowledge, the largest to date that has been done. And we published that. And based on that, we created a decision model. And what we see is that if you have a patient in good condition and no comorbidity, good functional status, it's probably they benefit very likely from intensive chemotherapy in most scenarios. However, patients who are ECOG performance status of 2 or do have comorbidity, these patients benefit more for 1-year survival of hypomethylating agents. So these are azacitidine and decitabine, and these are agents that will be more beneficial for the 1-year survival of our older patients than an intensive chemotherapy. So the short-term goal at 1 year, definitely many patients will benefit from hypomethylating agents, which are much better tolerated than intensive chemotherapy. So that's not bad, but it's still not great 1-year survival. So what happens in the last 2 years is we started combining targeted therapy for these patients. And we started combining azacitidine and venetoclax, which is a BCL2 inhibitor. And in patients 70 years and older, 75 years and older, with comorbid conditions who were not candidates for intensive chemotherapy. So these are the selected for bad outcomes patients. You can see that azacitidine indeed is not performing too bad. Half of the patients are still alive at 1 year. But when you add azacitidine, venetoclax to the azacitidine, not only do you increase the progression-free survival to now, 15 months, but you start seeing a tail of the curve of patients who seem to really keep being alive. It's not large numbers, okay, you have to be aware of the tail of the Kaplan-Meier curves, but I think we are beginning to see the light at the end of the tunnel here. And so my message here is don't be nihilistic when you have a 75-year-old with AML. There might be new treatment options with low toxicity that may be really beneficial to them. All right, for the last part of my talk, I'd like to focus on some key priorities for research and clinical development in geriatric oncology. And the idea is to feed your mind and make you think about how you could play a role in that and how you would want to go about it and implement that at McGill. So SCIUG has assembled a task force with really a lot of stakeholders to see, okay, worldwide, what matters most? What are really do we need to target in the next 10 years or so to improve the care of our older patients? It's published in Lancet Oncology. And for those who know of you who do not know SCIUG, it's the International Society of Geriatric Oncology. It's the expert society for us. And we want to strengthen the capacity of health professionals in the field of geriatric oncology. And we are all going to have to deal with that. And this is the priorities we came up. We presented that at United Nations 2 years ago. And we had done a first version in 2011. And in 2015, the United Nations had the Sustainable Development Goals and an increasing emphasis on non-communicable levels, cancer among them. So 4 domains: education, clinical practice, research, collaborations, and partnerships. Education-wise, I think we definitely are going to need a lot of patients trained in that domain. It's already half of the cancer patients, going to be the majority of the cancer patients who are going to be 70 and above. And so that needs to be integrated in a pre and postgraduate medical training programs. We need to provide educational activities for the continuous education, like this grand round, and combat ages by educating the public. In clinical practice, I think we have to build on these randomized studies and models, develop models to provide that optimal care. Each setting might have its own way of implementing things. We need to develop more guidelines for the optimal treatment of these older cancer patients. And I think we need centers of excellence. And in Canada and the US, we are developed countries. I think each university system should have a geriatric oncology program. I think it's such a major part of oncology, and there are such a need. We need to have experts. We need to have people doing research. We need to have people leading at the leading edge of clinics in this field. Under research, we need to improve the relevance of clinical trials to older adults with cancer. They are underrepresented, and also some of these trials have little information about how valid, how externally valid they would be. Is that superb FOLFIRINOX combination tolerated in patients with comorbidities? Well, how many had comorbidities in the trial? Well, big question mark. They didn't check it. So the cooperative groups in the US are actually developing a minimal list of comorbidities they are recording so that we can extract that later. We need to evaluate the benefit of this geriatric assessment allocated treatment and co-management on outcomes. I show you some things on that. And we need to start leveraging the personalized medicine technologies to increase the precision of cancer understanding in the management of these older adults. We need to develop and strengthen the links between SCIAG and the geriatric oncology workforce, the international agencies. That's a very much a political goal, but the experts cannot do it alone. This is a very large epidemiologic problem. Everybody has to get involved. If people do national cancer plans, this should be integrated. And then we need to create some global funding mechanism to foster professional developments, especially to help developing countries facing this wave of aging population that they will have to do with minimal means. So what do I suggest are key research questions? As far as the biology of aging and cancer, we need to move beyond predicting risk. There is interesting research made about how you can, in animals, predict the risk, increase the risk, decrease the risk of getting a cancer. But most of the patients we see have the cancer already. And so what happens after? And that's clearly a big question with not enough research behind it. How do the epigenetic changes of aging influence cancer prognosis, influence cancer response? Metabolomics. Many metabolites change with aging. Cytokines, cortisol levels, all that. How does that influence cancer behavior? Lots to learn here. Post-tumor interactions in general. How does tissue senescence, how do body senescence influence the behavior of cancer? How do the comorbidities they have? Diabetes is known to influence the relapse rate of colon cancer, for example. How can we modulate that? How can we understand that? Second question that is very hot right now is, does cancer treatment age the patient? We give DNA damaging agents. Does it create problems long term? there are many requests for applications by funding agencies about that, because it's an important question. We give a lot of treatment. Cancer itself can age the patient. It creates stress and inflammation, and we all know inflammation is not good when you age. As far as more clinical aspect, we proved that this geriatric assessment and management intervention works. So what now? What is the best format to conduct this intervention? Which is more effective, which is not? How can we implement them? If some of those of you are in the implementation research, that's a great implementation research field. Geriatric co-management, what's feasible, what works, how can we make it adopted? Now that we know that it works, now that we have outcomes that change and quantify, let's do cost effectiveness studies. People are often reluctant to add a whole geriatric oncology team to a cancer team, but general geriatric studies have shown years ago that they are cost effective. They are much more cost effective than a screening mammogram or than a dialysis. We need to have data on that in the cancer world. So this is something I think where our outcomes researcher can really get some nice studies going. Something that is hard in the field of cancer is treatment de-escalation studies. Many of the chemotherapies and other regimens that we've developed were developed 20 years ago. Since then, we've developed all these targeted therapies, all these improvement in radiation techniques. Can we de-escalate? Can we decrease all these steroids we were giving initially when the first HT3 inhibitor came? We showed steroids were improving things, but since then we've added other antiemetics. Do we still need all these steroids and their side effects, or can we decrease the doses? Plenty of escalation studies that can be done there. And then we need to leverage all that digital information we have. We sit on a trove of information. And as we said, these older patients are underrepresented in clinical trials. We need to find a way to extract these real world data and make our patients benefit from it. And I'm just going to give you one example of that. Oh, sorry, I have the clinical issues before that. So clinically, yeah, implement this geriatric assessment, spreading geriatric oncology clinic models. And I would target especially the academic and large centers. We have to be leaders in these academic centers. McGill, Moffitt, we all have to lead the charge here and really optimize the care of these older cancer patients and influence our entourage. And then we need to start leveraging elderly-friendly digital technologies. People are all starting to have a cell phone. They're all starting to use it for many ways. Our patients are much more receptive than we give them credit for if we give them proper training and make the technology non-threatening to them. So a lot of user practical implementation things to do. So can we go digital with geriatric oncology? There are many ways we can go digital. A very simple thing is to put the geriatric screening in your medical record. And this is PowerChart. And we have the soap-free screening tool, which is our geriatric screening tool available online. And by the way, it works as well or even better than the G8 if you are trying to choose a tool. I'm making a plug here. You scroll, this is between the lab results and the radiology results. So you can really just scroll through it, see what you find. And there are some suggestions. We don't make them automatic because you have to take the context. But suggestion here for that patient was to consult social work, OTPT, behavioral or language specialists. That's the mini cog that triggered that. Nutrition, neurology. So you pick and choose, but it gives you some clues at what might be done for this patient. Another simple way in a lower resource country was done by Enrique Soto in Mexico. they just give people a cell phone with a pace counter. And if they were reducing the number of paces a day they were making by more than 50%, the nurse was calling them. And it turns out that they frequently had grade 2 or grade 3 side effects. And that was a signal for them. So if you don't have the means to follow these patients very closely, this is a way you can do it with very simple methods. And as I mentioned, this is a representation of the underrepresentation of older patients in breast cancer studies in the particular case. So how do we generate evidence for these patients? We piloted something here. We piloted a remote consulting. We partnered with a community hospital, and we told them, you know, if you have completed cases and you want an input from our database of similar patients, send us a formatted email, we'll look into it. So they were doing, at the time, it was version 2 of our questionnaire, and an oncology workup. And if they had a treatment decision to make, they were sending us the email. We were searching the TCC database, summarizing it with an expert comment, and sending that back to them to implement as integrate in the treatment care as they wanted. What was the result of the intervention? We published that in the Journal of Geriatric Oncology. In 1 year, they referred first 31 patients, and we influenced treatment in 2 out of 5 patients, and we modified it in 1 out of 5 patients. The consultation was considered somewhat very useful in the majority of patients. Now, it may be that they were just nice, but for me, a more reliable indicator is that when we started the study, our colleagues were, well, that sounds nice. Yeah, let's do it. I mean, it was a bit lukewarm. Towards the end of the study, when we were saying, oh, we are going to close, we had people telling us, oh, don't close quite yet. I want to send you somebody. So that means much more than any questionnaire. It means that they really found it was helping them. Also, very interestingly, the response time, we had targeted to do it in less than 3 working days. And we managed to do it in 2.2 working days. So it was highly feasible time-wise to extract this data, format them, and send them back. So this is an interesting pilot, and we are trying to do follow-up studies and randomized studies. But as everybody knows, getting randomized studies funded through the NIH is a bit of a challenge. So we are doing also trying to learn about patients with comorbidities and doing machine learning studies to do that. And as a conclusion, I would say, yes, geriatric oncology can go digital, lots of opportunities. And just because my cousin was 90 years old didn't mean she couldn't get her first computer. So we're getting to the end of the talk. And in summary, I would say this. Integrated geriatric intervention have a level 1 evidence behind them. They should be standard of care, like any other level 1 evidence. Familiarize yourself with targeted and immune therapies, because you will increasingly see them used in geriatric patients, and they will be part of their list of medications. And don't be shy to use your favorite online medical reference site or application, because nobody can remember it all. I go to UpToDate all the time for my oncology targeted drugs, okay? It's just, as I said, once a month is approved. So you have to keep up to date, and you can only do it with digital help. There is a very rich field of aging and cancer research that's open, and you know, any junior investigator who wants to have a large open field and develop their research, that's a perfect place to go. If you want to learn more, connect with geriatric oncologists, well, come to SIAG in October 28th to 30th in Geneva, Switzerland, my hometown, is the next conference. The abstract submission deadline is April 29th. So if you have an abstract you want to submit, you can still do it. And I hope to see you there.
Thank you very, very much. Thank you for joining us and for this really excellent lecture, and congratulations on all the work that you've done in this field. It's actually very interesting and very topical, needless to say. If you want, the chat is open if people want to enter questions. I have a question for you, which is perhaps more of a concern. You know, we are in the socialized healthcare system. You that 50% of the population with cancer is over age 70. And my question to you is, if you talked about a geriatric intervention and how there's time to do a geriatric intervention prior to treatment because there's usually several weeks. Does this decrease if you do a geriatric intervention? Does this decrease the number of people that will be suitable for chemotherapy, or during this geriatric intervention, do you find that you kind of discuss with patients and realize that either they're too frail or they're not suitable? Does it sort of increase your numbers or decrease your numbers?
It can go both ways, actually. People have looked at simply basic geriatric assessment without interventions for a while, and a couple of nice systematic reviews of that. I would say in about 2/3 to 80% of cases, you decrease the dosage of treatment, the intensity of treatment, whether it's decreasing the dosage of chemotherapy, the type of chemotherapy, or simply avoiding it. And about 20% of the time, you are going to intensify the treatment, maybe add a modality or say, no, that patient, they may be 89, but they are in very good shape. They should be treated with some chemotherapy. So I think it can go both ways, a lot of time more decreasing than increasing. But also, one of the ideas behind doing these screenings is that if you want to give chemotherapy because this is a lymphoma you are trying to cure, you should be very proactive with supportive care. And if you are proactive and you give the growth factors and you really ensure the patient has support and so on, you may prevent a hospitalization. You may prevent complications that are definitely going to cost. And I think that's, we still have a lot to learn about, from a system point of view, what's the cost effectiveness and what is the, maintenance of independence outcomes and things like that. Canadians are usually very good at this system approach. The studies from the US tell you about the cost of the drug and the cost effectiveness of the drug. The British and Canadian studies tell us the whole picture. We need both. We need both of these approaches. Yeah.
We have a question here about pharmacists. What is the role does a pharmacist play in your assessment team?
That's great. Great question. So we do have a pharmacist with us in the clinic, and she initially, in our questionnaire, we had just simply the number of medications to define polypharmacy, because that's a whole chapter in itself. But that was like 90% of our patients. So what we did work, and it's work in progress, she decided, let's select 6 drug problems that she wants to address. So we looked at people who had both opiates and benzodiazepine, for example. Diabetic patients on insulin and diabetes medication to check for how they were taking it and updates and education. We did anticoagulants. That's another one. Another flag is vitamin D. We screen for vitamin D deficiency, and the vitamin D management is entirely done by our pharmacist now. The latest is people who are on low-dose aspirin. She reviews that it's not a primary indication, but a secondary one. So given the latest data from the studies. And so that's another point she reviews. We do the bone density, bone agents. That's also one. And then her favorite is she's hunting PPIs and is trying to track and decrease them. So we've gone to some targeted role. And then, of course, there is her role as a source of knowledge, which is invaluable.
Fantastic. It's coming on the hour, so I will have to close off the official sessions, but there are some important questions in the chat that I would ask you if you could please answer, maybe take a couple of minutes to answer the chat. Fantastic. I will have to close out the official session because it's 1 o'clock. But once again, thank you so much for joining us. Thank you for being part of this these medical grand rounds, and congratulations on all the work you are doing. It's very, very important work, and we look forward to having you back here. So I'll invite you to answer, and people can just enter their questions in the chat. Thank you once again.
Yeah.
Bye-bye.
Thanks, Martine. Thank you very much.
You're
Great
welcome.
work. Great work.
Thank you. Okay, so where do I find the chat here? Okay, let me see. Oh, probably I should stop sharing my okay, here we go. Let me stop sharing my screen. We can see everybody. And now here is the chat. Okay, so how to include older patients in research studies? Yep, that's a good one. The NIH has been working with geriatric oncologists across the US and multiple meetings about trying to make things easier. There is a working group that has tackled the comorbidity aspect of it. And there is revised. I'm
still with her.
Yeah, revised criteria. For example, creatinine clearance, if you look at the new studies, they usually lowered the limit from 60 to 30 milliliters per minute. And because for many drugs, as I said, tyrosine kinase inhibitors don't care what your creatinine is. So why would you need a creatinine at 60 milliliters? Do 30, and that's already a whole bunch of older patients you can put in the study. Educating oncologists and reminding them is good. I think the best way to include older patients in clinical trials is to have your research coordinator for the study do a systematic screening of all the patients who are planned to, have a certain diagnosis or are planned to have a treatment, and have them contact the treating oncologist. We're all very busy, and we forget, especially if you do observational studies, outcome studies. The best way is really to have somebody dedicated to tracking all these patients that are beginning treatments, and then put them on the trial, either reaching the oncologist, or sometimes they even accrue them. Just send us an email. We want to accrue these patients. Okay with you? We say yes, fine, and we go ahead.
Martine, I was wondering, are you hearing me?
Yeah,
Jose, yeah, I was wondering if it's appropriate to also, when we are in research, when you receive protocols to test a certain drug, is to inform or request to the pharmaceutical that they should include at least 40% of patients above 70, things of the sort, so that they're going to start thinking about including more older adults in their studies. Yeah,
so I don't know how it is in Canada, but the FDA has recently produced a document to encourage all drug companies to include older patients. It's not mandatory, it's a suggested thing, but they are trying to push for more information on older patients when they submit drugs for approval, and trying to, make, as I said, they can't make it mandatory because probably half Congress would be on their back if they were doing that. But they're strongly recommending that and asking questions. And that's very much part of the debate, is how can we incentivize drug companies to indeed provide data on what's the majority of the patients that are treated.
Yep.
Canada may need a different approach because, as you say, in the US, people are in it for the money. Okay, so
very good.
It's a major driver. You have to acknowledge the reality in which you live.
Yeah.
And so Canada, I don't know. You may do a working group. You might do the Canadian Drugs Agency might need your recommendation, and I might have a wait.
I will speak with Martine Put and maybe Doreen, also Dr. Wenshawa here, so that we can make progress in this direction. Thank you very much for being a great advocate for older people. Thank you.
You may want to speak with Harpreet Singh at the FDA, who was behind these recommendations. Yeah. And she can give you the FDA recommendation, then you can push it on the Canadian side, equivalent. Yeah.
Thank you. Thank you.
Yeah. Okay, so yeah, we had the one about the pharmacist here. As I said, very much part of our team. At which point in geriatric oncology patients, the oncology care becomes debatable, and what factors come into play to make the assessment? Yeah, so what is, in other words, what is appropriate and not appropriate use of chemotherapy, multimodality therapies, immune therapies, targeted therapies, you name it. I think the best use of that is really the goals of care approach. As in an age-friendly hospital cancer, we do ask what matters most to our patients. In the outpatient setting, we are trying to have a goals of care initiative in the US where we try to align treatment with them. And then I think the key answer to that is to know your numbers well. To cite the example of breast cancer, at some point, when you do adjuvant chemotherapy, you decrease the risk of relapse, but you may not necessarily have any impact on survival. And so the question becomes with your patients, I mean, how important is it for you to prevent relapse versus how important is it to impact your survival? And if you know your number well, you can inform your patients, and then you can make a decision together. And that's, sorry. So that's the main thing. I think the secret being, when to do active treatment or not. A geriatric assessment will certainly help you decide, is your patient healthy or frail, no matter what their age? And some treatments may not be worth it if you have a frail patient, because you're not going to be able to deliver it. Now, oncology care in general is always appropriate. Okay. What I mean is there is a lot of supportive care that goes beyond just pain medication. There is, you can do targeted radiation, you can do some interventions, and oncology care, palliative care is part of oncology care. A lot of the oncology is palliative. It may be a 10-year palliative treatment, but metastatic breast cancer can last for 10 years, but you're not going to cure it. So I would say I have a slide with a patient with a large liver mass, and the question is, should you refer that patient to the oncologist? And the answer is yes, because there are radioembolization, there is stereotactic radiation, there are pain treatments that we can do and we can choose from. And that necessitates quite a bit of knowledge. Some of you may be very comfortable with all the options of palliative care and familiar with them, but otherwise, it's always good to have some input. And there may be low toxicity targeted therapies that may be an option too. Other questions?
No further questions that appears on the chat, so we can consider your grand rounds as finished.